but irreversible. Hi everyone, today we are going to start our new session of enzyme kinetics, in which we are going to study about the types of inhibitors. Types of inhibitors. As you guys know, there are two types of inhibitors, competitive and non-competitive inhibitors. And where the competitive inhibitors look like the substrate and they compete with the substrate for the active site. If you guys know about the structure of an enzyme and then having active site where the substrate will attach. And from this side, there will be a formulation and activation, and it will convert into a product. But competitive inhibitor, it just look like a substrate. It will come and attach on that side, so stopping the V for the substrate. So if the substrate did not attach with the active site, then they will be no product. Okay? So the competitive inhibitors also having the two types, either reversible and irreversible. Both are going to attach with active site, but the reversible can be knocked out by adding more substrate while increasing the concentration of substrate. But irreversible can't be knocked out by adding the more substrate or increasing the substrate concentration. Okay? And what is non-competitive inhibitor? These inhibitor does not look like substrate. And secondly, these inhibitors can be attached at any site of an enzyme. It could be active site, could be allosteric at any site. Whenever the inhibitor will be attached on the enzyme, then morphologically the active site will be dissolved. And no substrate will become attached with it. So the activity of enzyme will be reduced. Okay? If you guys remember, we already studied about some graphing kinetics, the micro is maintain kinetics, and one is a line-level plot. Okay? In this class, we are going to study about how to identify the competitive inhibitors or non-competitive inhibitors. And these kinetics give about the two qualities of the enzyme. One is Remax, and second half of Vmax. And secondly, we also go through with a constant called the Km. Okay. Let's come and identify the parts. Okay. How we are going to identify these x-axis in the Michaels-Menten kinetics. On x-axis we have in just substrate. On the y-axis we have in velocity. Okay. And this part is Km. When the Km on the higher value, then it will be equal to half of Vmax. Okay, you already know that thing. And this is the Vmax because you already studied when the hyperbolic graph become flat, it will identify Vmax. Okay? This one is a normal hyperbolic, but this one is competitive inhibitor. Competitive inhibitors. In competitive inhibitors, there are two types, reversible or irreversible, but now we are only studying about the reversible. If you focus here, there is the green line and the orange line on the same way. Okay, there is no distinction, they are touching each other. So this point is the Vmax. So we can say the Vmax will be unchanged. Okay? And second is one more reason. If you get from the concept of competitive inhibitor will be knocked out by increasing the substrate. Okay? If you guys can take the Vmax hole here, okay, and the substrate and the concentration of substrate phosphate, then you got the Vmax. After that, adding the inhibitors, you achieve the Vmax on higher concentration of substrate. Okay? Seem like we already studied a competitive inhibitor can be knocked out by increasing the substrate. Okay? The Vmax will be unchanged because this is one point the maximum velocity that will be achieved by the increase in substrate. Other than if you want to increase, that will only increase by enzyme concentration. Okay. To deviate from the topic, now we will add over next points. If you guys check there, the higher Km. The value of Km is higher. And the substrate is going to increase, the value of Km is also going to increase. So whenever the Km will be increased, the affinity of enzyme will be decreases. This will be a second point. See the fourth and that is a second. And our third point is that you are getting the same effect. Okay? For example, it's a 5 gram and this is the 10 grams. Okay? On 5 gram, you are getting the same effect. But there was no inhibitor. But after applying some inhibitors, you guys are getting the same effect on the 10 grams. So, basically, the potency will be decreases. Potency will be decreased. If rated the potency means any drug that can be give a maximum effect with the lower dose, okay? Then the effect we are getting on the 5 grams is the same effect we are getting on 10 grams now. So potency will be decreased. Now I will talk about non-competitive to get some speed. The blue line you are seeing, the blue line, it is non-competitive. The non-competitive, you guys already know, in non-competitive inhibitors, by increasing the substrate on anything, the inhibitor will not knocked out. And enzyme, the activity will decrease because its active site already did not remain same after taking the non-competitive inhibitor because it's irreversible. In simple words, these inhibitors just destroy the enzyme. So, when the number of enzymes are getting less, so you guys already know that is the line, okay, of a normal Vmax, so it is. And after that, inhibitor, the Vmax will be decreases, and so we can make one point that the non-competitive inhibitors can decrease Vmax. Fine? And secondly, after getting the maximum dose, okay, you are getting this effect. So we can also say the non-competitive inhibitors can decrease the efficacy. The efficacy is the maximum effect finding drug. So you guys can see it for the maximum effect of a drug, but after giving a non-competitive inhibitor, the effect is getting decreased. So, we are done with the competitive inhibitors and also non-competitive inhibitors. But the competitive inhibitors having the two types, reversible and irreversible. The irreversible having the same things that we thought about the non-competitive inhibitors. The irreversible also decreases the Vmax. The Km will be unchanged. Affinity will be unchanged. Fine? And now he will talk, it's all the point, with the line Weber book brought. The line Weber with the same the presentation of a hyperbolic curve in the straight line. Okay? If you guys remember the point, the point where the line is getting cross, y-axis is equal to Vmax. Understand? And the point where the line is crossing x-axis is equal to Km. It's a simple trick to read the graph. When any line is going to cross y-axis is equal to Vmax. If any line is going to cross x-axis, this is Km in the line Weber plot. So the yellow line is a normal, okay? But after adding non-competitive irreversible inhibitors, the Vmax is going up. Okay? Mean the Vmax will be decreases. And if you are going to see this, the Km is unchanged. I will highlight it, but the Km will be unchanged. If you make a focus on the green line is making a theme point with the yellow line. So the Vmax is same. But if you guys focus here, the green line, it just closer to 0, so Km is increasing. So if you see the book, if you read deadlines, the competitive inhibitors growth each other, whereas non-competitive inhibitors do not. And competitive inhibitors increase the Km competitive. It is starting from a C here, COM, but you can make a mnemonic like COM, competitive inhibitors, like it will be increased the Km like that. And these things we already studied, the closer to zero, the y-axis, the higher the Vmax. So, in that graph, I will again elaborate the things. This one is a normal, uninhibited, and I already told you guys when anything is going to cross y-axis, it will be Vmax. If anything is going to cross x-axis, then it will be Km. X-axis Km, y-axis Vmax. Now if we edit the competitive inhibitor in a reaction, then of what? Vmax will be, you mean same. Okay? But our Km will be increases. Already, this line is saying the same thing. If the lines are closer to x-axis, they will be higher Km. And you guys are noticing this. The green line is a closer to O or x-axis. Fine? And if you add the non-competitive inhibitors, their Vmax will be decreased and they are having no effect on Km. Fine? This is all about the competitive and non-competitive inhibitors by the relation with Michaelis-Menten kinetics and Landwehr-Berg plot, and how can we elaborate these inhibitors by these kinetic theories and all the thing. Finally, this one is a graph. We already studied all the thing. You guys know the competitive inhibitors resemble the substrate, but non-competitive inhibitor don't resemble. Competitive inhibitor, if there's anything competitive, is reversible or irreversible, they will resemble the substrate. And second, they can be knocked out by an increasing concentration of substrate. Of course, reversible be do, but irreversible will not, and non-competitive also. They will bind to active site because competitive inhibitors bind to active sites. It is reversible or irreversible, both will bind with active sites, but non-competitive inhibitors did not. Mostly they will bind allosteric sites. Effect on Vmax, we already studied. In competitive inhibitors, the Vmax would be unchanged, but in non-competitive or irreversible, the Vmax will be decreased because the number of enzymes getting decreased. Effect on Km, we are increasing the substrate to overcome the enzyme, to overcome the inhibitors, to make the enzyme in good condition. So when we are going to increase the substrate, the Km value will be increased. But in irreversible or non-competitive, we are not using any substrate. So the Km value will be unchanged. And if you talk about the pharmacodynamic potency will be decreased in competitive inhibitor, because when you give a high number of substrate, the enzyme will work same. But in irreversible and non-competitive, the efficacy will be decreased, because when we are disturbing the enzymes, it will not work again as it was doing. So the efficacy will be decreased in both of sites. So did all about the enzyme kinetics. But I want to make a difference again between the competitive and non-competitive. It is a competitive and it's a non-competitive. The competitive is similar to substrate, and it is not. It binds with the active site, and it's not. And it can be overcome with substrate concentration, but the non-competitive did not. The maximum velocity or the Vm remain unchanged in competitive inhibitors, but in non-competitive it will be decreased. In competitive inhibitors, the Km is higher due to overcoming the inhibitor, and we are going to increase the substrate concentration to Km is higher by the non-competitive inhibitors. The Km will become and remain unchanged. Okay? Now we are going to start pharmacokinetics. Okay? In the last we were starting out with enzyme kinetics. Now we are going to talk about the pharmacokinetic. In this, we are studying all the impact of drug's ability to achieve the desired results, and pharmacokinetics includes absorption, distribution, metabolism, and excretion. These 4 things are including the pharmacokinetics to achieve and get the desired result of the drugs. But before we are starting our bioavailability, first I want to discuss about the routes and how the drug can be administered. The drug administration. The drugs can be administered by entry route, beta entry route, and other routes. The entry includes all the routes that use GI tract and can be used if we give drug oral, sublingual, and also rectal. The parenteral includes IV, IM, and subcutaneous. And the others includes inhalation, intranasal, intrathecal, and topical, like creams and ointments that absorb by the skin. Fine. I am just telling about this all administration because the method of administration of drug affects how much it will be available to the body, and the amount of drug available to the body is called bioavailability. Okay? Secondly, the bioavailability is a fraction of administered drug reaching systematic circulation. And it is suppose we are taking 100 mg or tablet, and from then the 50 mg absorbs and remain unchanged. So bioavailability will be 50%. Okay, but for the IV, those the bioavailability the 100% because you are injecting the drug directly into the blood system. For the orderly F stand for the bioavailability, typically less than 100 due to incomplete absorption. There are 2 points: incomplete absorption and the first part, metabolism, and can be calculated from the area under the curve and the plot of plasma concentration over time. In this paragraph, we get the 2 points. First for the IV dose, the bioavailability is 100%, and the for oral dose, it's less than 100 because of 2 points. First, due to incomplete absorption, and second, first part, metabolism. Fine? And what does it mean of that the last line of the curves? Let me elaborate it, Goff. Suppose this is a 0 point, and you are given the IV dose here. As you injected the dose, it will give a peak of this, okay? And retain the interval of time, the x-axis is for the time. With gradually time, the dose will decreasing, okay? But for the oral, for example, at this time at 1 o'clock, you guys take 1 tablet, and it given to digestion system and GI to take slowly to absorb to your body, and it gives a peak point here, and then it will be excreted. Fine? And from this graph, you can find the bioavailability by the area under the curve. Like, that is the graph, and it's the curve, this area with bioavailability. Okay? And for that, to give that formula, the bioavailability is equal to area under the curve, the oral multiplied by dose of IV, and dose of oral multiplied by area under the curve of the intravenous drug, and we have to do it now. Fine? Simply, I again summarize the bioavailability that it is the amount of drug that is available in the body after the administration. And in the IV dose, it's the 100%, and for the orally, it's typically less than 100%. Now we was joking about the first part, metabolism. Let me explain, because when you guys take any drug orally, that drug is absorbed by the liver. And some drugs are rapidly metabolized in the first part, that liver having some zones first, second, and a third. And the third zone, there's a cytochrome for 15 enzymes that will metabolize that drug. And during this, there's some two phases of the conversion in which the drug will become polar ionized or metabolized by the liver and excreted from the body. Okay? So it's some of drugs that are quickly metabolized in the first path, and the amount will be decreased that reduces circulation, and it can be reduced in liver disease patients, because you guys know the first word metabolism means occurring in the liver. If some patient having the liver disease, the liver is not working good. So the drug is going to the liver and facing some metabolizes or the reactions. It will not face any reaction, and this reaction and dharma will be decreased, and amount will be increased in the body. So the one of the Klenker statement, the first pass metabolism can be reduced in the liver patients. Fine? The patient with the liver disease. Now we will move to our next topic. Now we are going to start volume of distribution. The volume for distribution is a theoretical value that relates the drug amount to the plasma concentration. It is a value of the drug, only it is an estimate of a drug. How much it will be distributed. Okay? For that, I will want to make an example for you guys. For example, these are 1 gram of some molecules, and this is a 1 liter of food. So if I combine the both things, and it will give like that 1 liter having 1 gram, it's a 1 gram, and it's a 1 liter. So the total combination is at 1 gram per liter. Okay? So again, I take 1 gram dose, and there's some fluid, but I did not know it's an unknown quantity, okay? Unknown volume. And when I found, after mixing that, I come with same results, 1 gram per liter. So I will make an assumption that if I am getting the results 1 gram per liter, then this fluid should be or will be 1 liter. Fine? And again telling, in the volume and distribution, we did not know how much the volume the body having. We know the amount of administration, and after administration, we can calculate how much into blood. So by this trick, we can identify the volume of the distribution. Okay? by this of a formula, the volume of distribution, it will indicate you might have read and first we have the right amount of drug in the body that you are injecting, for example, is 1 gram, 1 mg, and the plasma drug conservation is 1 gram per liter. What is the volume of distribution? When we divide it, both the thing, it will be 1 liter. Understood? So, we will move forward. It's a simple and theoretical value, it's not an actual value. And secondly, the volume of distribution is a used for determining the dosage. For example, effective drug. For make a drug more effective, we need the dose of 10 mg per liter. And the volume of distribution is 10 liter. Okay? Then how much dose we will need? So we'll multiply the 10 with the 10 equals to 100 mg. We need 100 mg drug to achieve the concentration of 10 mg per liter, because this is a consideration where the drug will give maximum effect. So the useful thing of a volume distribution in determining the doses of the drugs. So secondly, the dose will distribute according to compartments. According to compartment. So we should have know about the compartments. The compartments in which the body will give like that. Okay, sorry for inconvenience, and like I told your body, first, I having a patient having the 60 kg, and according to the take, the total body weight, into total body weight, 60% water. In 60% water, then total body water will be 36 liters. After that, it will divide into extracellular and intracellular compartment. The extracellular having the 12 liters, and intracellular have 24 liters. Fine? And then the extracellular having the further two compartments, like plasma and interstitial fluids. The plasma would be 3 liters, and interstitial fluid be 9 liters. So the drug is coming here, and as it will be going from the intravascular to the extracellular fluid and to the plasma and interstitial fluid. This is the V of the root of a drug of the distribution. So we'll study how the things will be going on in the liver and the kidney diseases increase the volume of distribution. Because in the liver and the kidney disease, it decreases in protein binding that can increase the volume distribution. You have one more point that liver and kidney, why liver and kidney what? The liver make the albumin or the proteins, and kidney having some disease in which the patient can lose the protein, like nephrotic syndrome. In that diseases, the amount of protein will be decreased in the body, so drug will not combine or bond with any protein. And any protein. So there will be high concentration of a drug that is free. Okay. As much of drug is free, the volume of distribution will be higher. The drug may be distributed in more than one compartment. Nonetheless, the more effective for the drug with a low volume of distribution. I've elaborated this part first, like how the drug can be distributed in more than one compartment, what properties are needed for all the things. If you see this table, the volume of distribution can be low, medium, and high. If the drug is only present in the intravascular compartment, then the volume of distribution is low. And when it is happening, when the drug having the large and charged molecules and it is binding with the plasma proteins. And if the volume distribution is medium, then drug can be going to extracellular compartment from intravascular compartment, and it is due to the small hydrophilic molecules. And if a drug having a high volume of distribution, then it also going to tissues and the fats. And it is due to the small lipophilic molecules of a drug, especially if bound to tissue proteins. And especially the drugs are distributed to vascular compartment will be decreased, will be less volume of distribution, they will be large, charged molecules, and often they will bind with proteins. For instance, warfarin having the volume distribution equal to 9.8 liters, drug that accumulate in the tissues having the very high variant volume distribution due to the small lipophilic molecules, and they are especially bound with the tissue proteins, and often uneven distribution body like chloroquinines having a highest volume distribution about 13,000 liters, like they will be if you found, and chloroquinine in the intravascular compartment, your volume distribution will find way less amount in their intravascular, but it will be very high in the interstitials and tissue compartment effects. And secondly, if we talk about the protein bindings, already we are saying here again about the plasma protein binding. Tissue protein mitochondrial spine to plasma protein, UV albumin, and this may hold them in a vascular space. Therefore, they have a lower volume of distribution. And this is all about the volume of distribution. If we summarize that volume of distribution, then it is a theoretical value that make an estimate how much the drug is distributed to the compartment of the bodies, and in the liver or kidney diseases. In liver and kidney disease, the volume of distribution would be increased because it's less production of protein and less amount of protein binding with the drugs, and the volume distribution would be increased. And secondly, if a drug having the high volume of distribution, then it's lipophilic, and having a small molecules, and it is going to tissues and fats. If having very low, way less volume of distribution, then it is in the intravascular compartment, and drug having the large charged molecules, and they are binding with the plasma proteins. Find it all about the volume of distribution.